right, so our next team is Northwestern, who has actually been one of the few teams that actually has the same collective background. Nicely done. So, all right. Okay, so who's presenting?
I'll be presenting, or I'll be sharing the slides.
Okay, great. All right, take it away.
Thanks, Abel, for calling out our coordination. I'm glad that you appreciate it. I wanted to first thank you all for coming to our presentation. We're the Northwestern University AI Bowl team and are here to present HF Connect. And so my name is Lindsay Zimmerman, and I'm joined by team members with technical backgrounds in informatics, engineering, and data science, and also with the much needed content expertise from the fields of public health, medicine, and mHealth. We're also joined by 3 expert mentors, Dr. Luo, Dr. Ahmad, and Dr. Akuwosa, helping to guide us both in our AI and ML methods, and also to provide their content expertise related to cardiology and heart failure. And of note, we also plan on engaging heart failure patients throughout the process to ensure technology is guided by patient-focused principles. And so heart failure is a chronic health condition in the United States, which affects more than 6.5 million adults and disproportionately affects Black Americans and those with low socioeconomic status. In 2014, nearly 1 million HF-related hospitalizations occurred, leading to 11 billion in direct healthcare costs. Disparities in racial and socioeconomic groups are major problems in HF outcomes and may be due to differences in guidelines-directed medical therapy, or GDMT. GDMT is a set of medications and one of the most important modifiable clinical interventions in HF care, and has been shown to improve outcomes in HF with reduced ejection fraction, or HFrEF. Provision of GDMT is severely lacking, with some studies showing that less than 25% of HFrEF patients are on appropriate doses of GDMT medications. There are a variety of patient, provider, and systems level reasons for this, from issues such as lack of clinical availability and provider lack of familiarity with GDMT guidelines, as well as patients being unable to reach clinic, lack of insurance, and low self-care efficacy. As with HF outcomes, disparities in GDMT are known. Compared to white Americans, Black and Hispanic Americans with HFrEF are less likely to be started on GDMT. And we believe that by addressing issues related to being on optimal GDMT, we may be able to improve HFrEF management and reduce disparities between groups. So our goal is to empower HFrEF patients through the provision of tailored interventions that will address their unique needs and help them achieve optimal GDMT. We will first leverage the large and diverse Northwestern patient population and use clustering techniques to identify novel factors affecting the achievement of optimal GDMT goals. And this clustered analysis will inform our patient-facing intervention, an all-in-one HFrEF management mobile app called HF Connect. HF Connect will empower patients and facilitate access to healthcare resources through a chatbot with personalized content based on their unique patient profiles and a support chat room that provides a venue for information exchange among HFrEF patients at Northwestern. And so in order to better understand the different profiles of HFrEF patients, we will be applying clustering algorithms using demographic and comorbidity features for patients. On this slide, we've listed 5 clustering methods which will apply and compare, and we aim to discover distinct patient profiles at higher risk for not being on optimal GDMT. We'll investigate these clusters further with screening tools that will allow us to better understand the factors leading to not being on optimal GDMT and tailor the app-based content, which will be described on the next set of slides, to each patient. And now Yu Yang will introduce our product.
Thank you for that, Lindsay. So the main component of our intervention is a chatbot that patients can use to receive information for HFrEF management. Following registration on our app and clustering of patients, we'll deliver a unique in-app survey based on cluster for better understanding of the factors contributing to not being on optimal GDMT in each group. These surveys, alongside future focus group interviews with patients, will be used to tailor cluster-specific content in the app. Cluster-specific information will help us address unique patient-facing barriers to optimal GDMT in each group. For example, linkage to specific community resources or transportation options for outpatient visits. Through this approach, we will ensure an app that contains both general as well as subgroup-specific information relevant to the lives of different HFrEF populations. In addition to the main chatbot feature, our chatbot has 4 additional types of functions. Our first module is a daily check-in that will notify patients with individually tailored daily content, such as making sure to log their medications for that day. We believe that these daily reminders will be helpful for self-care efficacy. Our second module is a blood pressure tracker and visualization tool that will prompt patients to record daily blood pressure measurements. Patients will be recommended to contact their physician if the blood pressure is abnormally high compared to their historical measurements through an anomaly detection approach. The third module will prompt patients to record daily medication dosing, with the option to use their camera to verify correct medications via optical character recognition of the prescription bottles. Similar to worrying blood pressure trends, inconsistent medication logging will prompt contacting the physician. The last module seeks to improve patient activation via an instructional video with suggestions on talking with the physician given to patients prior to appointments. Prior research has shown this approach to be very effective, and we will use natural language processing to develop a more engaging pre-visit module than past research that will talk the patient through the video and include support for potential questions they might have along the way. We also plan to introduce a complementary chat room feature to support the chatbot. We will invite our users into a WhatsApp chat group that is integrated within the phone app. The WhatsApp group will allow patients to connect and exchange relevant information regarding HFrEF management and get answers to questions not currently supported in the chatbot feature. A central benefit of this approach is that the chat room will allow us to mine the chat log data and utilize topic modeling to identify common types of questions that patients are asking. This will serve to iteratively improve our chatbot content. We have prepared a short video to help illustrate our idea. So here we start in the chatbot's daily check-in feature. The test patient, Jane, receives a daily prompt to take their medications, bringing her to the medication tracker portion. She has the option to either type or scan the prescription bottle here. After completing all daily tasks, the app will default to the main screen. Here, Jane can use any of the core features we had mentioned previously. She can ask the chatbot questions related to HFrEF care in the resources section, interact with other patients in the community tab linking to the chat room, or record BP and medication data in the record feature. We believe that our team has unique strengths that will help bring our idea to reality. As part of Northwestern Medicine, we have access to a very large and diverse patient population that is receiving care for HFrEF. In addition, we have support from highly qualified mentors in AI and heart failure care who are passionate about this project. As for the solution itself, we believe that our approach has the advantage of being entirely patient-facing. It does not interrupt clinical workflow, and it does not require integration with the electronic health record, which will greatly improve the speed at which we can deliver our solution. And more importantly, our patient-centric approach offers multiple avenues to improve patient activation and self-care efficacy. Our patient clustering approach tailors content to patients that is especially relevant to their unique situations. This will help to address existing biases and disparities in the care of HFrEF. Patient feedback is also involved in the development of the app, and patients will be critical providers of much needed content for each patient cluster. This is our timeline for our goals. So in the next 5 months, we will set out to accomplish multiple goals. We will begin by working to refine our patient clustering algorithms to identify and characterize patient clusters. We will also work with patients to gather user feedback on our app design at this stage, and patient feedback will be involved throughout the design process. Next, our team will begin programming the actual app content, including the chatbot feature and the WhatsApp integrated chat room. Once initial prototypes are completed, we will recruit a larger cohort of patients to iteratively conduct product testing and evaluation to see if the app is having any impact on their health behaviors. And that's the end of our presentation. We want to thank everybody for listening to our pitch, and we welcome any questions.
Great, spot on time. No time out from me. Okay, so we have 10 minutes for questions.
It's Shannon, I'll start. So I would classify this as a digiceutical, which is a relatively recent concept in the healthcare IT space. What evidence have you guys found either for heart failure specifically or for other clinical conditions where these types of directly client-facing applications are effective? And perhaps you could layer that on with effective across socio-demographic strata that would, in order to rectify disparities.
Kevin, do you want to mention the study that we found?
Yeah, so this product is mostly motivated by an app developed by some folks at the University of Colorado. They were implementing this patient activation tool. It wasn't even an app that coaches them on communicating with their providers on GDMT and getting on GDMT. And they found a significant improvement in getting the patients on the right medications. And we wanted to take that tool to the next level by making a more engaging app, an engaging tool that they can use. And we want to make this tool as like evidence-based as we can. So I think that we're basing our tool on the most up-to-date evidence that we can find in the literature.
Thank you.
Yeah.
I think, I guess maybe this is more of a comment. When we, deployment of these types of apps, I think because we're, the target is ultimately health disparities, that community, like when you talk about, the emphasis on community and how that is brought to bear in the design of the app, thinking about the real world application, I'm particularly interested in how, like the engagement model with the patient or the member, the individual, sorry, I'm coming from peer space, the individual, and how you plan to, because ultimately if, to achieve the desired end, that engagement piece is gonna have to be critical. Otherwise it will be something that's not leveraged, right? So how do you work that engagement? Like, how do you work that into the design so that, if you say people are going to be able to leverage WhatsApp group, there tends to be some, sometimes people don't like being added to WhatsApp groups, right? And even more so if they know that there's going to be some trace, the data is going to be available, even if it's just clinical data. There are issues with the trust and, data being shared or collected, so how do you plan to get over those barriers to really bring in the folks that maybe, have less access, right? But that need to be engaged because of the specific health outcome that we're trying to eliminate the disparities on.
Yeah, I think that's a really good question. And I think the answer is going to be tough in that direction. For one, we're kind of relying pretty heavily on patient opinions. So what they tell us about, what kind of barriers do you think people might face joining this kind of app, and if they have any questions on security issues. So I think that will help to inform our build of this. And also, we decided on the WhatsApp integration because of the time constraints of this current project deadline. So in the future, we are planning to have the chat room function integrated within the app itself.
Patients with heart failure are a relatively vulnerable group. They tend to be older. In a study I'm doing with patients with heart failure, my mean age is something like 82. Many of them are not going to be great with smartphones. How are you going to overcome those technological barriers for this patient population?
Yeah, the adoption of smartphones among older patients is pretty poor, but we believe that the adoption of flip phones is pretty good actually. So we are considering transferring some of this functions in our app to be SMS based.
But even so, like, is there anything additional you could do to help this population with that? It feels like the major barrier for this intervention in this group.
There was another idea that we had was to provide access for the app to the main care providers of these heart failure patients. They could be family members or like other care workers that might be taking care of them. And because the app doesn't really require or like doesn't really include that much like sensitive like health information, then we don't need to worry about like potential like authentication or authorizations and things like that. So we intended this solution to be as portable as possible, so that like even if the patient themselves may not be able to access it, we have multiple channels of getting this solution to the hands of the patients.
So for this, I mean, Dr. Tara brought up a good point, but I will have to say that there are a lot of restrictions or regulations related to, even if it's personal information, even if it's not necessarily PHI.
Mm-hmm.
And so you've got power of attorney, you've got legal guardian, you've got authorized agents. How would you, and oftentimes those require submission of documentation that you're an authorized individual, authorized to view this person's personal information. You've also got some, you've got like CCPA, so there's a lot of different areas where you may want to consider, and I don't know if you've thought through how you would kind of get over those barriers, right? Particularly for this population, which I didn't even think about the point that they're probably going to be a lot older. And so it's even more important to safeguard their personal information because they are vulnerable. So how does that factor into your solution?
We will likely be engaging the patients at the point of their provider office. So I think it's at that point where we're going to have to be able to get the legal documents for any family members or caregivers to utilize the app.
Thank you.
Any other questions? We have 2 minutes. Okay.
One
Well,
other
hearing
thing I
none.
want to clarify is, if possible, is so you
Yeah.
have, they're chatting with a bot, but they're also going to be put into a WhatsApp group. And how does that all happen? And how do they connect with real people versus a bot? And wasn't totally clear on that.
Yeah, so there's a separate function in the app. So there's one widget that will connect to the bot and then one that will connect to the chat room. And the purpose of the chat room is to answer questions that we didn't think about in the bot. And then that could help to improve the bot in the future.
Or it could just connect people to a group or peers who share the experience, which would be potentially useful as well.
Great. All right. So we're at time. So again, thank you, Team Northwestern. Thanks for taking the time to present. So next team up is Michigan State.